Hello, everyone, and welcome. I'm Christina Hawes, Community Engagement Coordinator for the Community Outreach and Engagement Office of Wilmot Cancer Institute. I'd like to welcome you to today's webinar, Together Against Colorectal Cancer, Raising Awareness and Finding Hope. This webinar is a part of our Community Conversations on Cancer series, an educational series designed to inform, educate, and disseminate best practices in cancer research, clinical care, and community engagement. It is sponsored by the Office of Community Outreach and Engagement, CERTEC, and the Community Cancer Action Council, or CCAC. This live event has been approved for one AMA PRA Category 1 credit, one CNE credit for nurses, and one contact hour for social workers. If you'd like to receive credit for attending, make sure to fill out the post survey. The link will be provided when this webinar closes, as well as in the follow-up email. Our presentation today will be followed by a facilitated Q&A session. Throughout the presentation, please feel free to enter any questions in the Q&A box located at the bottom of your screen. Now, let me introduce you to our experts. Dr. Totadri Dhimal is a surgical resident at the University of Rochester and a fellow in surgical health outcomes reaching for equity, or SHORE. SHORE works to foster collaboration and focus on community-based participatory research to ensure that diverse voices are heard and valued throughout the research process. Next, we have Don Armstrong. As Director of Community Engagement for Cancer Supports Community Rochester, Don works to promote cancer screenings within communities of color and rural areas. His work is informed by cancer statistics that reveal significantly higher late-stage cancer diagnoses for residents in underserved communities. Since joining Cancer Support Community Rochester, Don has established 12 points of access within communities of color and 3 outreach groups. Through these groups and other partnerships, CSC Rochester has distributed cancer screening materials and colorectal fit kits to more than 3,300 residents in communities of color and rural areas. And as a side note, Don Armstrong is also one of our CCAC steering committee members and has been a participant for several years, and we are very lucky to have him. So, without further ado, let's start our webinar, and I will hand this over to Dr. Dhimal.
All right. I'm going to unmute myself and let me share my PowerPoint. Right. Can you see my PowerPoint?
Perfect.
All right. Thank you, everyone, for joining us here today. I'm Dr. Tari Dhimal, a surgery resident and postdoctoral research fellow at SHORE. And like Christina mentioned, we do a lot of research with cancer and work with our community to learn from our community members how we can improve cancer-related cares. I do not have any financial disclosure to report. The key objective of this talk is to discuss some of the epidemiology of colon and rectal cancer, anatomy of bowel. We'll talk about screening guidelines, who should get screened, some signs and symptoms of colorectal cancer, and differences in management of colon versus rectal cancer. And we'll end a talk with discussions on organ preservation in rectal cancer. So, what is colon cancer? So as you can imagine, cancer is your own cell that has gone rogue and tries to invade different part of your body and causes a lot of medical problems. In bowels, we generally have 4 different layers, as you can see in the image here. And when we say colorectal cancer, usually the cancer starts at the top layer in the mucosa, where the cell goes through continuous cycle of death and regeneration. As you can see, the colorectal cancer, usually we define stages based on where the tumor is. If you have tumor just at the top or the first layer of your bowel, that's usually called localized disease or early disease. And as it gets advanced, it will start invading through this wall and keep going down and then spread. And we'll talk more about the management of different types of colorectal cancers in the upcoming slides. So how common is it? So as you may be aware, colorectal cancer is the 4th most common cancer and 2nd leading cause of cancer death in the US. Globally, by 2040, it is predicted that the annual cases will be 3.2 million and 1.9 million deaths annually. In US, the incidence rate has slowly trending down, but over the last decade or so, this has plateaued and in some cases actually gone up. The rates of rectal cancer especially has risen over the last decade, and the cases of colon and rectal cancer in young adults has also gone up. At home in New York State, the rates of colorectal cancer reflect the national rate, and at Monroe County, we have around 35 cases per 100,000 patients, which is also average for the state and national averages. Before we dive into the management and screening of colorectal cancer, let's talk about bowel anatomy. And when we say colon, what does that mean, right? So when we say bowel, we usually refer to two different types. So you have a small bowel and large bowel. Small bowel is, as you may have guessed it, smaller and usually 8 to 12 feet long. And it's fairly uncommon to have cancer in your small bowel. Small bowel plays a major role in absorbing all the nutrients that we eat and provide energy. Large bowel, on the other hand, is larger and about 5 feet or so. It's divided into different segments, and we'll talk about that briefly. The goal or the function of large bowel is to absorb the water and all the nutrients that get doesn't get absorbed, that becomes a stool, it'll help bulk up that stool. It does not have any essential function beside bulking up the stool. So you could remove a large chunk of colon or all of your colon, and you won't have a significant impact in your life, functionally at least. Um, so as we talk about different parts of colon, we usually partition them in a few different sections. So you have right-sided colon or ascending colon, you have transverse colon, descending colon or the left side of colon, there's sigmoid and rectum. And that little thing on the right side that's hanging out, that's your appendix, where you get appendicitis, and people usually remove that. If you have a cancer in any different part of this colon, we can remove just that part of the colon and connect things back together. And we'll talk a little bit more about surgery down the road. So let's talk about cancer. Usually, uh, the cancer starts in your colon as a polyp. It's a benign growth in your colon that over time gains mutations in DNA and becomes more and more invasive. This process takes time, up to 10 years, but in some patients it can be sooner. That's why we talk about screening, because with the screening process, you can identify these polyps at an earlier stage and remove them before they turn into cancer, or detect cancer at earlier stages before they have time to become invasive and spread across your body. So who's at risk? There are a certain group of patients who have a higher risk of colorectal cancer, and they are patients with uh, familial syndromes such as Lynch syndrome, or those with a family history of colorectal cancer, and patients with inflammatory bowel disease like Crohn's disease or ulcerative colitis. And if you have any family members with the colorectal cancer history or worried about genetic testing, Wilmot Center has support services to do the genetic testing. So feel free to reach out to our team members here. If you don't have these high risk factors, then average lifetime risk of having a colorectal cancer is around 4%. And this risk is a continuum. It's not a fixed yes/no number. So some people will have a slightly higher risk and some people will have slightly lower risk. There are some non-modifiable risk factors, such as age. As you get older, you are more likely to get colorectal cancer. Males tend to get colorectal cancer slightly at a higher rate than females. And some races, such as African Americans and Native Americans, tend to have a slightly higher rate of colorectal cancer. And there are other modifiable risk factors, such as metabolic syndrome, obesity, diabetes, alcohol use, smoking, physical inactivity. All of these factors increase your risk of having colorectal cancer. Again, none of these things by themselves tell you that you're going to get cancer or not. It's just a continuum of risk, and you are at a slightly higher risk. And at an individual level, this small changes in risk might not be significant, but at a population level, when you look at millions of people, this leads to hundreds and thousands of new cases of colon or rectal cancer. So, who should get screened? So, United States Preventative Service Task Force recommends that everyone with the age between 45 to 75 should get a routine screening. If you are older than 75, then you should talk to your doctor about the risk and benefit of screening. There's varying based on your health and other factors, you may have a benefit in getting a screen done versus not getting a screening for colorectal cancer. And patients with high risk factors that we discussed previously should also get screening. These individuals should have their screening done based on their personalized risk factors, and the timing and when it should start varies. I'm not going to go into the details about what that should be, but if you have these risk factors, talk to your doctor and they will help you guide when you should start getting screening and how frequently you should get screening for colorectal cancer. So, what are the treatment modality for colorectal cancer? So you have colonoscopy, and that is a gold standard treatment. I'm going to focus a few minutes talking about colonoscopy, but you also have this other test that you can do. Colonoscopy is not just a diagnostic test, meaning it does not only see the polyps, or cancer, but it's also therapeutic that you can remove the polyp. So you prevent that polyp from potentially being a cancer down the road. And depending on what you find in your first colonoscopy, the frequency of how often you should get tested or screened varies. If you have a higher risk polyps, then you should get screened sooner. If you don't have any high risk polyps, then you can repeat your screen at a 10-year time period. And again, these discussions should be done with your doctors to figure out what is best for you. Not all colorectal cancer comes with signs and symptoms. That's why screening is very, very important. However, there are times where patients will have some signs and symptoms, especially in the later stages. So if you have bloating, anemia, weight loss, fatigue, these may be things that you want to talk to your doctor. None of these signs and symptoms are specific for colorectal cancer. So if you have any of these, this does not by any way or shape tell you that you have colorectal cancer. It's just something that you may want to talk to your primary care physician when you go see them, so that if you do need further testing, if you're not up to date in your screening, they can help you get the screening done or further testing if needed. Why should we screen, right? Again, it's all about trying to identify colon or rectal cancer at an earlier stage. As you can see here, this is a uh, stage distribution by the stages of colorectal cancer. So we divide them by local, regional, or distant. Like I showed you a picture earlier, local disease usually means the tumor is within the colon. It hasn't spread up into a regional areas. If it's regional, then the tumor has invaded through the colon walls, and then you have some tumors in lymph nodes and surrounding area. And the distance means the tumor has gone to your liver, lungs, brain, somewhere far away. And this is important because if you have a early stage colon cancer, we have excellent treatment, and 5-year survival rate is upward of 90%. If you have regional disease, the survival slightly lower, but still fairly good, around 70% or so. But if you have a distant disease that is metastatic, the survival rates drop to less than 20%. Wilmot Cancer Center has established multidisciplinary team and excellent physicians and care providers to help you take care of if you or some of your loved ones do get colon cancer. But I wanted to reiterate that at earlier stage, we do have very excellent treatment modalities to help you achieve an excellent surgical outcomes or oncologic outcomes. So let's briefly talk about management of colon and rectal cancer. And I want to highlight some of the similarities and differences on how we manage colon cancer versus rectal cancers, and they are different. So some of the similarities is if you have suspicions of colon or rectal cancer, then we do some of the basics uh, care or managements, which is if you haven't done, if you haven't gotten already colonoscopy, we get a CT scan of your chest and a belly to see if the tumor has spread across. We do test for some tumor markers, and I'll talk about that briefly in the next slide or two, um, and some molecular testing. This is where the management diverges for colon and rectal cancer. In the next slide, I'll talk about colon cancer, and then we'll go ahead and talk about rectal cancer and how they differ. So colon cancer, you can usually bucket them in two different categories. They are operable, meaning the colon cancer is within the colon or it has spread to nearby area, but we can safely remove all of your tumor with surgery. If that's the case, then you go ahead with surgery first. You get surgery, and depending on the tumor characteristics, you may need chemotherapy afterwards. Radiation generally is not utilized in management of colon cancer. If you have a metastatic disease, meaning the tumor has spread across, then you get chemotherapy first. And depending on a very select few cases that you may be eligible for surgery, but chemotherapy would be the definitive treatment. Um, I wanted to briefly mention some of the exciting treatment modalities that are on the horizon. So now we do have some targeted therapy with immunotherapy. So earlier I mentioned about molecular testing. So patients with specific mutations in DNA that leads to microsatellite instability or mismatch repair protein deficiency, they can use immunotherapy to treat their cancer. It's currently approved for advanced stage and metastatic colorectal cancer, but it's exciting to know that we do have these other options. And like I said, Wilmot Cancer has experience using this new modality of treatment, and we're glad to provide this cutting-edge therapy to our patients in our community. So rectum, let's talk about the function of rectum and how it differs than colon before we talk about the management of rectal cancer. So rectum is a reservoir for your stool. So stool goes to the colon, it bulks up, and it gets deposited into your rectum, and it has all these nerves and sphincter muscles to help us decide when we need to go to the bathroom. So we can plan around our work schedules and our life, right? But it's also different in terms of anatomy. It has different blood supply. It also does not have one of the outer layer that colon usually has. Thus, the rectal cancer is a difficult to do surgery because it's in a narrow space and tends to have a high rate of local regrowth. Because of these factors, we manage rectal cancer differently than colon cancer, where surgery is usually the first option in colon cancer. In rectal cancer, you usually get treated with radiation and chemotherapy first. If it's early stage rectal cancer and usually limited to the mucosa or the first layer of your bowel, then we do surgery first. But if you have a locally advanced disease, the major treatment initially is to do chemotherapy, radiation therapy first, and then reevaluate, and then you may or may not need surgery. And I'll say why I said may or may not. So what does the surgery for rectal cancer entail? Rectal cancer surgery, proctectomy, which we say in medical terminology, has shown to be the gold standard and excellent outcomes for our patients. But it comes with some inherent risk and functional compromises. So there are two varieties of proctectomy or removal of rectum. First is abdominal perineal resection, which basically means you remove your rectum and you also remove your anus. So you end up with a permanent ostomy. And as you can imagine, having a permanent ostomy comes with its own risk factors and complications and some other dysfunctions as listed in the slide. The other surgery is low anterior resection, where we remove most of your rectum, but we leave your anus and some distal part of your rectum and reconnect it with the colon. Unlike APR, you don't need a permanent ostomy, but generally most of our patients will have a temporary ostomy during the treatment phase. Uh, and this surgery, though you do have your rectum, or not rectum, but you do have your continuity, comes with some functional compromises too. So you could have incontinence, meaning now you don't have the reservoir that rectum used to be. So people tend to lose control of their bowels. You could also get sexual dysfunction and have some issues with quality of life because of incontinence. So as you can imagine, even though surgery has an excellent oncologic outcomes, you do have to make some functional compromises with surgery. So patients who get chemotherapy, this is very select few patients who get chemotherapy and radiotherapy and do not have any clinical evidence of tumor on their assessment are potentially eligible for what we call watch and wait protocol, which basically means you do a serial surveillance of the rectum to see if the tumor is there. And as long as there's no evidence of tumor, you can forego the surgery. And as you can see here, one of our colleague, Dr. Loria, who is also part of the SHORE, did a paper few years ago that showed the rates of proctectomy in US has gone down slightly. Concurrently, the rate of organ preservation, or watch and wait, has gone up. And these rates are mostly seen in advanced colorectal cancer because those are the patients who get neoadjuvant or chemotherapy and radiation therapy upfront. Patients who have early stage cancer, we are still going ahead and doing surgery and removing the rectum because that is, again, the gold standard care. But as you can also imagine, it comes with some functional compromises that you have to take for the excellent outcome that surgery brings. So I'll talk briefly about our paper that was published earlier this year. And we looked at patients with early stage rectal cancer and who had rectectomy, meaning they had removal of their rectum. And we wanted to see how many patients had APR, which is basically removing the rectum and the anus and getting a permanent ostomy, versus LAR, which is removing the rectum but attaching your colon to the anus. So you do have a continuity of your bowels. We had around 3,000 patients. And as you can see, more than half of our patients had APR, which is removal of their rectum and anus, and ended up with permanent ostomy. And what we also found was around 1 in 5 patients did not have any tumor in their surgical pathology. So because they got chemotherapy and radiation therapy, like 60% of those patients got chemotherapy and radiation therapy. So that treatment helped get rid of the tumor, which we know happens in the advanced stage disease, and it's common now. Not common, but it's practice in locally advanced disease. So what does this paper tell us? So first thing, there are opportunities for potential organ preservation in select few patients with early stage rectal cancer, but we need a robust data and clinical trials data to support this finding because you do not want to not provide best oncologic care in hopes of good functional outcome if you're going to have a recurrence or disease progression if you avoid surgery. So it's a fine balance of, do we do a surgery and achieve a best oncologic outcomes that comes with some functional compromise, or do you preserve function but take some risks with oncologic outcomes? And these are tough decisions that you need to make with your doctors, your surgeons, your oncologists. And we do have ongoing clinical trials in early stage rectal cancer regarding organ preservation. And Wilmot Cancer Center actually is one of the centers that's doing this clinical trials. So unfortunately, if you or your loved ones do happen to have this cancer, we would be happy to discuss these clinical trials and help you see if these treatments are fit for you. So transitioning to some of the ongoing questions in rectal cancer management. Again, the fine balance of excellent oncologic outcomes and excellent functional outcome is something that we strive for, and more research is still needed to to be utilized in patients across the board because, like I said, watch and wait is not for everybody. It's just for very select patients who have complete response, meaning no tumor after they get a neoadjuvant therapy. We still need to look at the quality of life piece on patients who avoid surgery for dysfunctional outcomes. And one of our colleague, Dr. Hilde Chu, is doing a qualitative study talking to rectal cancer patients in our community to see what are important to our patients and how can we learn from their experiences about this management and how can we improve care to our future patients. Um, and lastly, like I said, immunotherapy is an exciting new treatment modality. And hopefully, that will help more of our patients that otherwise would not have these options a few years down the road. And overall, the goal of us as doctors and at the University of Rochester and Wilmot Cancer Center is to keep pushing the research of cancer care and help our patients the best we can from either awareness, screening to the treatment, and provide like I said, the cutting edge treatment that's currently available. With that being said, I'm gonna transition to uh, Don, who has done an excellent work in the community, and I'll let him talk about the ongoing work that he's doing.
Well, thank you, Dr. Dhimal. That was such a great presentation, and just appreciate your work uh, in this field of cancer. And just I was just blown away. I'm actually caught up in your presentation, and so I'm trying to gather my thoughts here with regards to talking about cancer support community. And to all attendees, I want to express my appreciation for this opportunity to talk about the work that Cancer Support Community of Rochester at Gilda's Club has been doing for the last 2.5 years now. And I want to disclose that I have no financial interest in this presentation. About 2 years ago, we took a look at some statistics with regards to colorectal cancer, and we're very concerned about the Crescent area and what was going on in rural areas. And what we found in various reports is that there's certainly a need. And I think Dr. Dhimal really made a great point about this is one cancer that does not always reveal symptoms. And so it is quite possible to reach a later stage in colorectal cancer before you even realize that something is going wrong. And so our goal has always been to really advocate for early screenings or early diagnosis, at least being in sync with the recommendations for screenings. And so I opened up this presentation by talking about something that we ran across early in our process. We started administering colorectal fit kits. I'm going to bring up my PowerPoint here. And this, can you all see that? I'm assuming that you all can see this.
No, it's
Um,
not up yet, Don.
it's not up yet. Okay, let's try it again here. My apologies for the delay here. I'll just keep, there we go. Apologize.
Perfect.
Okay, thank you. So a couple of years ago, we really started taking a close look at what was going on in terms of screening, particularly for colorectal kids. We are closing out Colorectal Cancer Month, and so again, about 2 years ago, we started this initiative. And I'd like to share the story of one of the early recipients of our Fit Kit. He was a farmer, so some of our work is in rural areas. A farmer who responded to one of our advertisements with regards to these free kits and really took a look at his grandchildren. He was 62 years of age, great fit, no health problems that came to mind, and just feeling pretty good about his health situation. But something just compelled him to take advantage of the opportunity to pick up one of our fit kits. He made the journey to our location, and he was shocked to find that when he took the test, he got a positive result. A positive result in of itself does not necessarily mean that you have cancer. It's a red flag to seek out a doctor. This particular farmer didn't have a doctor, so we worked with a partnering agency here, cancer services providers, and certainly they were able to provide great assistance to retest him. And to make a long story short, he certainly had significant issues with his colon. Several polyps had to be removed. Fortunately, they were caught early enough. And so he was able to receive the appropriate treatment. Other issues were found, and he's been on the road of recovery ever since. And it was at that time that we began. It was just one anecdotal situation, but we really felt that this was the kind of initiative that needed to go forward in rural areas and communities of color because we are concerned about the late diagnosis that many individuals in these communities have. And as Dr. Dhimal mentioned, it's all about early detection. Your chances of survival are very, very high if the symptoms or if the cancer is caught in the earliest, stage 1 or stage 2. So we have been for the last couple of years distributing colorectal kits. I'll share some statistics in just a moment, but just a little information about the kit. When we are doing our outreach, and I'll explain to you our strategy for outreach, we actually stress colonoscopies. As Dr. Dhimal alluded to, it is the pinnacle of testing. There's nothing to replace it. Certainly, we are not advertising these kits instead of a colonoscopy. Our conversations start out with simply asking a question. Are you of age? Have you had a colonoscopy? And for those who, for whatever reason, refuse to move forward in what they should be doing, we have this as a part of our plan to at least allow them to go home and take a test. And of course, if something is found a red flag is found, then of course, usually these individuals have all the motivation needed to call their primary care physician and schedule a conversation around what next steps should be taken. And so we stress that a colonoscopy is what we are advertising or what we're promoting. But for that, again, for the portion of in particular, I find men are very, if they're not feeling ill for any reason, it's just they may tend to be a lot further behind in getting screened. And so this initiative, and again, is really for those within that age range that Dr. Dhimal alluded to, between ages of 45 to 75. We push them. And one of the features is that one gets a result within 4 to 6 minutes. And it's very much like a COVID test. Of course, this is a test of a stool sample as opposed to what you do for a COVID test. And yet the process is pretty similar, and the results are rendered within 4 to 7 minutes. Now, our strategy at Cancer Support Community is to realize that you need a lot of support, a lot of help to push an initiative beyond 1 month, the colorectal month. This has now become a year-round, perennial process for us, a perennial initiative for us. And so we've been fortunate to really reach out through our various points of access to find individuals that in some cases are on the cancer journey themselves. They're cancer survivors. Others are just interested in what we're trying to do. We were recognized by the city of Rochester, members of both our Latino group and our African American outreach groups, for the work that they've been doing around cancer screening and with emphasis on our colorectal kit initiative. And these are just some of the leaders of groups. And our approach is to really engage individuals who are interested in this, to bring them into our place of business, to offer programming for them, to do some educational sessions so that they are well informed about how best to engage our communities. We are typically at the health fairs that are sponsored by various organizations. As mentioned in my bio, we have made connections with 12 different agencies, organizations from the faith-based community, from the health community, and beyond, residential locations for senior livings. We do business with management companies just so that we have access to individuals that may be behind on their screenings. And it's really through the efforts of these outreach groups, and we're talking about 45 men and women who are a part of various groups that we have in doing the great work on a volunteer basis. In terms of statistics, since we started this initiative 2.5 years ago, we have distributed over 1,500 kits within Rochester and beyond. We have been as far as Harnell and other Royal locations. We've been out to Williamson, and we're just trying to spread our wings as far as this initiative will take us. We have 62 confirmed positives. And now I emphasize these are confirmed positive. We're quite sure that the number is higher, but those who receive our kits are not required to tell us what the result is. We give them instructions of what to do if it is positive. And of course, even if it's a negative result, we're still promoting timely screenings, the colonoscopy as being the best test currently available. 91 colorectal screening presentations have been given to our community and beyond. We have touched or reached out or have had interactions with over 3,600 residents of Rochester and beyond. And through this efforts, we have established 6 new points of access. And again, to define what I mean by points of access, I'm referring to organizations or facilities that engage the population that we are targeting for the initiative. Whether people come to frequent, whether like YMCAs, senior living institutions, clinics, things of that nature, we consider them opportunities to engage groups at a larger capacity. And particularly for organizations that offer health fairs, we find that many churches have their own versions of a health fair, and we are building partnerships with them, relationships with them, so that we are invited to attend and to give the educational components of our presentation. And also, we take our kits along with it. A couple of photos, and I'll wrap this up. This is an example of a couple of our volunteers, outreach volunteers. Again, really doing a great job. First, receiving education and information from us at our headquarter location on Alexander Street. And then once they feel prepared to do a presentation around the kit, they hit the roads, hit the streets, and hit the various events on behalf of Cancer Support Community. We are also at places like the St. Michael's Great Initiative, Rochester Hope Initiative, that's held every weekend, I believe. And we have one week that we're able to go, one weekend, I should say, that we're able to be there every month to engage the population that comes through there. We're talking in many cases over 200 individuals that frequent this location for the various services that are offered and the various partnerings. UR Wilmot is there, and we're just a part of the conglomerate of organizations that are educating our residents, those who attend. And just a couple more examples where, again, we do not just pass out the kits. We want to make sure the recipient understands how to use them. Again, before we've gotten to the point where we're doing a demonstration of use, we have had the discussion about a colonoscopy. We've asked questions about where they are in terms of being screened. And really, it's not just colonoscopies that we're promoting. It's screening for various types of cancers based on age. and just a couple of other examples here. And in terms of our strategy, I think what we do that's perhaps a little bit innovative as a organization is really support our volunteers first and foremost. We bring them in. We have meal programs for them. We have recitals. We have all kinds of activities. As a matter of fact, they inform us how best to provide services to them so they can refresh themselves for the work to be done. This is not easy work for those of you who are out there all the time. We understand that it is not easy to do outreach. And so we are very much interested in expressing our appreciation, not just by way of words, but really by training, by providing meals, providing celebrations, recognizing their anniversaries, and a host of other activities. And so it's been a privilege to be a part of this initiative and these work groups that are, I should say, outreach groups that are just doing tremendous work on our behalf. Just another example of a cooking program. Now, this is actually for our volunteers, for our outreach team. Again, pouring into them before they pour into the community is our approach to outreach. And with that, I will, at this point, turn it back over to Christina. Thank you again for this opportunity.
Well, thank you, both of our presenters. I love coming to these because I always learn just as much as everyone else that attends. So it's always interesting. Thank you both. I want to make sure that everybody in our audience, just in case, is putting any questions into the Q&A box. I know that we have several that are in there, so we're going to get started right away. Let me add Dr. Fergal Fleming, who is actually a participant today, but I'm going to pull him over here to become a panelist, just in case there are some questions that come up that he might be able to answer. Perfect. Okay, so let's get started as he comes on. So actually, there are several in here. We will start with, does fiber help reduce colorectal cancer risk?
Sure, I can take that question. There are some studies that show that fiber does reduce, but it's as a mixed study. So it's always good to take fibers. And like I said, with all the risk earlier that I mentioned and the benefits, these are small changes that you take and they add into your risk or benefits, right? So just because you take fiber doesn't mean you can't get colorectal cancer. If you don't take fiber, you get colorectal cancer. Same thing with smoking or drinking, right? Just because you drink doesn't mean you'll get colorectal cancer. It's just a combination of these risk and benefits. So fiber is good for you and you should take it. There are some studies that show that it will reduce your risk of colorectal cancer, but again, these are small risks that we're talking about. So it's not a definitive thing that will decide your future of getting cancer versus not getting cancer.
Okay. And from your lovely picture, it looks like having a balanced kind of diet, lots of fruits and vegetables and whole grains is usually a benefit all around, not just for
Yes.
reducing risk.
Yeah, and that's the idea, right? With everything that we talk about, it's not about just hyper focusing on this one little risk. It's just having a balanced diet and healthy exercises habits that will overall impact how healthy you are, and that will impact your risk and eventually, even if unfortunately if you get one of this cancer, how you respond to the treatment and how you benefit from it.
Okay. All right. So this next one, what about Cologuard for screening? So actually, let me kind of split that up a little bit. So Don, from the photo that you'd use, so Cologuard is a brand of
It is.
screening that's sent
Mhm.
out. So it looks like you use what generally are called like FIT kits or FOBT kits for
Yes,
your screenings.
indeed. And to explain the difference between the two, Cologuard is the type of test, for those who may not be familiar with it, where you actually send in a sample to be diagnosed by a laboratory and await the results accordingly. A fit kit, again, is a home kit, and that begs the question, is one more effective, more, higher level of sensitivity. And the reality is that they're pretty close. They're pretty close. In all cases, we, again, are after that part of the population that won't do any, just not doing anything. They're not. They're not doing the Cologuards, and sometimes if there is a drawback to the Cologuard process is the time that it takes to get a result. And so, in efforts to really put a little bit of the onus on the recipient to at least take some initial first steps, and we actually initiate. But that is really the difference. One will give you a result at home, where the other, the Cologuards, you would wait for the result once sent into for to a lab.
Thanks for that, Don. And welcome, Dr. Fergal. Nice to see you. Or Dr. Fleming. Nice to see you.
Fergal's fine. Christina, Fergal's fine. Hi, thank you. Sorry, just had a little technical difficulty, so I had to jump onto another computer.
No worries.
Um,
So with this, I guess just as a follow-up, so we know what you're handing out, and it sounds like the one that you're getting is kind of the instant gratification. You can find out right away what it is, and then you can follow up. And it's on you. You have to follow up with your doctor. A lab's not going to call you
Mhm.
and tell you that you should call your doctor. You need to do it yourself. So with the Cologuard, how effective is this? I know that colonoscopies really are the gold standard for screenings, but as Don said, there's a lot of people that just won't get a colonoscopy. So
mhm.
in regards to that, I mean, how effective is Cologuard as a screening method?
So it depends on your baseline risk. So the important thing to recognize, you know, the way when people see the advertisement and then they got the tiny writing at the bottom of the screen, which goes by really fast. What that's telling you is if you were at average risk, meaning no, say, history of inflammatory bowel disease, no family history of polyps or cancer, you would fall into an average risk category. And that's what the studies were done for Cologuard on. If you have one of those risk factors, you probably should have a conversation. You should have a conversation with your primary care about whether what is the best screening test for you. Um, but for so it Cologuard is a great test, but it's important to know whether it's a good fit for you and your health in terms of your issues. And the other thing just to be aware of as well is the cost, because again, you know, it's sometimes for some of the insurer, the payers, they won't cover all of it, or they'll only cover a part of it. So you just, you know, just being aware of these issues. And the other key thing I say to people all the time is um, you can get the Cologuard done. If it's positive, you're gonna have to get a colonoscopy. So some people are happy
Mhm.
to say, "Hey, I want a one and done, just do a colonoscopy over with." But for some patients, it's a really helpful test if they have concerns about bowel prepping or the idea of getting sedation, etc. It's a really good test for appropriate people.
So it sounds like if you're at average risk, the best test is the one you get done, just the one
Correct.
you take.
Yeah,
Okay.
Yeah.
we would always rather a test being done than not done. Yes.
Okay, I'm going to be skipping around a little bit here because I know that some that have come up I've heard actually quite a few times before. So this one, and I'm not sure if you'll be able to answer, but do we know
Hmm.
why the cases are rising in younger adults now?
No. We
Oh,
don't. And it's super important to say that to people. More from what I would say anecdotally is when I care for a lot of patients under 45 who have colorectal cancer, and they might read online that it's X factor or Y factor, and then they feel they did something wrong, etc. And I really stress to people, we don't know. We know it's rising. There's a lot of research going on in the space. But I'm always very careful to say to people, we simply don't know for sure, because I think that there could be misconceptions that somehow someone did something wrong around their diet or their body weight, etc. And I think that's unhelpful. We simply don't know. Same advice. I think you guys covered it already. A healthy lifestyle, good fiber intake, exercise. You know, these things. It's kind of like once these things. These tick all the boxes. They're good for your digestive health. They're good for your cardiovascular health. They're good for your mental health. So it's just that advice applies to just your overall health. Um, but definitely not to say we're at a point to say we know why.
So stay tuned.
Yeah,
Yep.
Okay.
correct.
So Don, I have one for you. I was once asked by community, does the fit that you offer have an expiration date and what is the accuracy?
Indeed. So each kit does have an expiration date, and we are usually 2 years ahead of the expiration date. So the kits that we're distributing now do not expire to the end of 2026.
Mhm.
And the sensitivity rate is within 5% of the Cologuard sensitivity rate, which is high 90s, or I'm sorry, mid to low 90% sensitivity rate. So very comparable. And so
Okay.
it's also interesting to state that the a fit kit actually is a blood stool test. There can be other
Mhm.
issues that would
Hmm.
trigger a positive. So a part
Right.
of our education is to say that, listen, don't freak out if you have a positive result. It's just reason a good cause to call your primary care physician to have the discussion because it can be a couple other possibilities.
Yeah.
Okay. And with that, so since you were talking about the screening, and the
Mhm.
ages, I know that we have all talked about the ages. Why does screening end at 75?
Um, I, c- I can take it. So it,
Sure,
it
go for it.
depends on your risk, right? So like I think of two questions that you should ask is A, does this patient, right, like have a life expectancy of 10 years or more? And if you do detect something, are you going to do something about it? Is patient willing to go through all the chemotherapy, surgery, all the treatment? And that's a decision that you have to make with the patient. So if patient is like, whatever happens, I'm not going to do anything about it, then there's no point putting a patient at risk of doing a colonoscopy, right? Because whatever you find, you're probably not going to do anything about it. So it depends on how healthy the patient is and what are the risks and benefits of if you do find something, what are you going to do about it? And Dr. Fung, I don't know if you have anything else to add.
Yeah, no, it's you always want to be aligned with the patient's own goals in life, right?
Mhm.
So what I always say is if you're over 75 and over, have a conversation with your primary care. Um, it it sounds a little morbid, but the reality is these tests were designed when the average life expectancy was about 77, 78 in the United States. So essentially, initially it was 70, then it was pushed out to 75. Our fastest growing demographic in the United States is 85 and over, actually, in overall population. So what I say to any people that ask me this question, I get asked it a lot, and you're 75 and over. If your overall health is good, have a conversation with your primary care about your options. Um, Doing a bowel prep when you're a little older is harder. Sedation is tough. It can make you feel a little bit more out of sorts. So this might be a group of patients where, to your previous question, maybe Cologuard is a good option. Um, but it also goes back to the information. Um, if the person's if the patient themselves are saying, you know what, I want to take a minimalist approach to my life and my health, I just want to enjoy my life, then I would say, well, maybe getting a colonoscopy is not the best option for you. But it's very much above 75, it's more nuanced. I do a lot of colonoscopies in patients who are 75 and over, but we definitely have a more nuanced conversation about their goals, etc. And I go through the risks of the procedure, which are a little higher around sedation. And that might be a group of people that non-invasive procedure like Cologuard is a really good option.
So it seems that for those that are under 45 and then those that are over 75, it really becomes talk to your doctor as the best
Yep.
step to really see what to do.
Well, two things. Talk to your doctor and also making the difference. When we use the word screening from a healthcare perspective, we think in terms of people without symptoms, right? If you have symptoms, that is a symptomatic scope. It's a very different thing. So I tell all, if I'm talking to people under 45 and they have rectal bleeding, I say, just kind of like Don said about the other piece, don't freak out that you have cancer. It's far more likely you have bleeding, hemorrhoids, etc. But the flip side is don't dismiss your symptoms. If they, come and talk to us, go see your primary care. Let's get it worked out for you. I mean, either way, we can help you with your symptoms, in terms of if it's hemorrhoids, There's things we can do. But the key is if you're under 45 and you have symptoms, it's most likely something benign, but come talk to us. And if you're over 75, same thing. If you have change in bowel habit or bleeding, give us a call. Come see us. We'll figure it out.
So it's always a good idea if you're ever concerned to talk
Sure.
to your doctor first.
Absolutely. Yep.
Absolutely.
Yes. Okay. So this is a very interesting one, and I've had actually microbiome come up several times frequently within the past year or so. But is there any research happening that you know of? Because I know a lot of you really have been focusing more on the treatment aspect.
Mhm.
But has there been research happening about microbiome and colon cancer risk?
So the microbiome research is very much kind of still at that early black box phase. We know it's super important. We know it probably plays a huge role in terms of risk and also outcome, but we simply are not at a point to say a certain profile is a good or a bad thing. I don't think we're quite there yet. I think the biome is super interesting in terms of all digestive diseases, but we're probably not at a point yet to say um, I don't think we're at a point yet. I go back to what you said before. Stay tuned. Hopefully, in the next 5, 10 years, we're going to have a better handle on its role in our health.
Okay. Oh, this is a very interesting question from Joyce. I'm finding one of the reasons that folks are afraid to have a colonoscopy is fear of perforations or
Yep.
rifts in your colon. So how
Yep.
common is that?
Not common. It is in someone without any other risk factors, which would be prior abdominal surgery, etc., the risk is low. It's about 1 in 600 to 1 in 700. So it's not nothing. And it's something that when I'm talking to a patient, I will counsel them on in terms of a risk. Um, so it is not zero, but it is quite uncommon.
Okay, and we're gonna do our last question, I believe, because we're running out of time. So if there's anything that's left in here, we'll get to it, and I'll make sure that I send it out with the follow-up email.
Sure.
But for this one, is there a benefit to getting the surgery? Dr. Dhimal, you talked about how the rectum is quite frequently removed even after you found that there's no tumor. Uh, is there a reason for that? I mean, is there what is the health benefit for this removal when the tumor's completely gone?
I'll take that one.
Okay.
So first of all, it's important to recognize that where we are in 2025, we're not at a point that we can always tell people with complete accuracy that their tumor is gone. So it's important, and we do this to express there's diagnostic uncertainty, meaning you've had a great response to your treatment, but when we look at your scans, there's still some scar there, and we cannot tell you for sure if there's cancer cells or scar left behind. So we might say to you, and I have this conversation pretty much every month in my office. I'll say, I don't know for sure if there's cancer cell left behind. Here are the two options, and we go through them. One is to have surgery, recognizing maybe there's no cancer cells left and it's all scar. Or two, we observe the situation, recognizing that if it is cancer cells, it's going to regrow. So that's very much a conversation where you go through your estimated risk of the risks and benefits and try and help the patient come to very much a patient-centered decision. And this very much comes down to individual patients, how much uh, weight or importance they place on issues like their fear of the cancer coming back, their fear or concerns about having surgery, etc. So it's often a multi-part conversation between the specialist and the patient to try and make sure they feel they have all the information so they can make an informed decision for themselves.
Well, thank you for that answer. I think that does help to clear things up because I was wondering that myself.
No,
Um,
it's a very good question, and patients ask it all the time. It's a good question.
Okay, so I'd like to, since we're out of time, I'd like to thank all of our presenters and thank Dr. Fleming for hopping on to help answer some of these questions for us today. A special thank you to our interpreters for ensuring that the webinar has been accessible to our deaf community members. So make sure that you fill out our follow-up survey sent to make sure that we're sending the content that you're interested in hearing about. And you must fill out the survey in order to receive continuing education credit. The link is in your webinar confirmation email. So the webinar has been recorded An email will be sent with the link to the video and then answers to the questions that are left in the Q&A box. Thanks again for joining us, and we will see you at our next community conversation.
Thank you.
Take care, everyone.
Bye-bye.